Yeah, we've been doing things with grafts, the same thing for over 5 decades. And the mode failure is the graft vein anastomosis. Every access has its own peculiar mode failure, be it a fistula, be it a graft. One of the reasons grafts don't last so long is not necessarily in the conduit of the graft itself, it's at the graft vein anastomosis. Numerous things have been tried after a surgical anastomosis has been made. We've got balloons, we've got drug-coated balloons, we've got all kinds of other devices that have been tried, and really nothing has worked effectively at all. So we're always looking for something that is going to solve a real problem. The graft vein anastomosis is the problem. So we reach a point in time where we can't technique it out. And many things in medicine, when we can't technique a surgical problem out, we are defaulting to some kind of device to move on for the next iteration away from what we have been traditionally done. Well, the EndoForce is giving us a completely different fluid dynamics, I think, at the graft vein anastomosis. The typical graft vein anastomosis is an end-to-side anastomosis, meaning that the blood itself is hitting, if you like, the opposite vein wall, causing an endothelial buildup, causing a stricture. With the EndoForce, what we're doing is creating a functional end-to-end anastomosis. I believe it creates a laminar flow. Therefore, the failure mode is not going to be the stenosis nearly as much as we have seen with the traditional surgical anastomosis. Well, the new device, what do we hope? We want longevity out of our accesses. There's 2 things we need for access for the dialysis patient. Number 1, you have to be able to get a cannula in it to get the blood out of the patient's access over to a dialysis machine to be effectively dialyzed. You need to have adequate flow to do that in the access, and we need to be able to cannulate the access. Then what we would really want out of this is to get longevity out of the graft. We would like to see a long period of time so further interventions aren't necessary. And we already know that once a graft vein anastomosis starts stricturing down, becomes hemodynamically significant, the interval period of time that it is going to occur again after an intervention has taken place is getting shorter and shorter and shorter. Then we have to default sometimes to a whole different access. We want time without further interventions.